Okay, and I'll start recording and sharing on Facebook.
Okay, that's perfect. So I will also start sharing the screen. Do you want to start the session in some more formal way, or do you want me just to, do you want us to start speaking? Chaitra.
Hello. Hi, I'll just introduce our panelists first, and then you can take over, Professor Janusz. So hello everybody, and thank you so much for attending this webinar on intercultural learning to improve access to healthcare. So the official title is From Cultural Competence to Cultural Humility, a shift necessary for patient-centered individualized healthcare. It's being presented by Dr. Janusz and Thikiri Yee. So they are, just to introduce them before they start. So Professor Janusz is a Professor of Medical Education, Vice Dean for Development of Education and Head of Center for Medical Education at the Medical University of Lodz. He's also working with multiple international institutions which deal with health professions, education, and is also an AMEE Executive Committee member. His main professional interests include medical and academic professionalism, intercultural competence, and interprofessional education, and he uses arts and humanities in health professions education as much as he can. And Thikiri Yee is a graduating student from the Medical University of Lodz in Lodz, Poland. She has experience in tutoring preclinical courses, was also a student task force member in AMEE 2019, and she presented her project there. She's also a representative within her university student government. So she has a lot of experience in this. Her current interests include medical professionalism as well as healthcare for refugees. So this is our webinar for the third day of our Access to Healthcare Global Health Weekend being organized by Scopy and IFMSA. So today we are looking at global health and access to healthcare across the world and how we can improve it worldwide. And thank you for everyone who joined in on the social media activities yesterday and day before yesterday, which looked at your local city and then your national organization and your country. So without further ado, I'll hand over to Professor Janusz.
Okay, thank you very much. So thank you for this introduction. So we don't need to introduce ourselves. What you can see now is our university main teaching hospital, usually full of students, not currently, as you know, because of the COVID pandemic, and we'll talk a little bit about this later. One of the interesting things is that the all 12th floor of this incredibly huge hospital is a fully equipped simulation center. So at 12th floor, we have simulated departments, clinical departments. We have even a fully equipped emergency car next to the simulation of the street where we can teach our students, when students can learn emergency medicine. When we were, may I ask you the question, if now, do the cameras sort of obliterate your view or no? Because for me, it's just that it covers part of the screen. So, okay, it will be better. So look, thank you very much for sending us the pre-workshop survey. This was really very helpful. And what we could see, first of all, is that 74% of participants indicated that this will be your first session on intercultural communication. 26% indicated that you already have experience in this. So from people who did not participate in that kind of sessions, there were just very important, very general expectations, just to learn more about issues that are not covered by teaching at your school. And I really like the last point. I don't really know for sure, but just I want to learn something new. And I think this is just the main point. And we received about 100 descriptions of expectations and questions. And in fact, it very strongly influenced our presentation. We will make a short introduction, but majority of what we'll be talking about arises from your questions that will show on the screen. What you need to understand is that it is a really huge subject, and you may be a little bit disappointed because in fact every slide of our presentation, it's a little bit like opening a box, showing you the content and moving to another one. So that's why if you find it interesting, if you find it useful for your community, we will be very happy. I will be very happy to identify more experts that may work with IFMSA and will present webinars on particular issues that I will mention here. I guess you can hear birds singing very loudly, but I hope it doesn't interfere. This is just a nice place I'm living. We are presenting, it's impossible not to mention that we are presenting this webinar in an extremely complex moment. And I don't mean COVID, I mean what happens currently, mainly in the USA. And just one thing I need to say, that we cannot detach ourselves from everything that happens now. And even if you are from the smallest country where you believe that there is no racism and there is no discrimination, just stop believing, stop thinking like this. Racism, discrimination are everywhere. And it's an absolutely fantastic book called White Innocence by Gloria Wekker. She's a scientist, researcher, and activist from the Netherlands, which is for people who may believe that they are not responsible, that they are just for what's happening, that for people that live in their cozy environment, reading this book is a little bit like getting just a punch in the face because it opens your eyes. So please read it. Thikiri.
Hi, everyone. Well, thank you, Chatra. Thank you, IFMSA, for hosting this webinar for this Global Health Weekend. Chatra already said I'm a graduating student. I recently graduated from the Medical University of Lodz here in Poland, and I have worked with Professor Janczukowicz on multiple occasions, especially in the field of medical education. It's been about 3 years now since I've met and have started working with him. So, and this is my first time co-hosting a webinar, so I'm very excited. I would like you attendees, students, fellow students, to write, say hello, write where you're from, and maybe let us know what year you're currently in, because the topics that, as the doctor said, a lot of the topics are going to vary in terms of complexity and variety. So yeah, it'll just help us if you tell us, at what stage of the medical education you are at. So before this webinar, you guys sent in your responses on, your student expectations, what you hope to learn what you hope to get out of this webinar. So you wrote, learning about other people, tips, practical tips on how to help and treat patients by putting aside their differences, developing humanity and compassion, etc. And all of these, of course, are very important. Some of these you will learn with time and with experience as you encounter different patients throughout your rotations, whether it's from your own community or from others. And after you, as you progress on to become a physician, there are a specific set of challenges that you'll have to deal with. And these three main ones, number one, of course, is communication. Yes, communication. Without that, we cannot, we cannot have a true patient satisfaction. So communicating with patients across that language barrier, and because there is miscommunication, you have misunderstandings. So for example, the patient does not understand how to take a medication, and so they end up just not taking it altogether. And that can result in inappropriate care because the patient is not feeling better, or inappropriate care because of the physician or the provider's own prejudices and stereotypical ideas. Mm-hmm. I see that you've sent in your responses. Some of you, thank you for that. Okay, now just quickly about the definitions of cultural competence and humility, right? For most of you, this is your first time maybe coming across this topic, being introduced to this topic. So I would like to share what exactly is cultural competence. And as defined by the AMC, the Association of American Medical Colleges, as well as the LCME, the Liaison Committee for Medical Education. Cultural competence combines the tenets of family and of patient and family-centered care with an understanding that there's going to be some social and cultural influences. And those influences are going to affect the quality of the patient services and treatment. So that's the main definition. There are standards for reaching cultural competence, right? So both faculty, both teachers and students have to demonstrate an understanding of the manners in which people from various cultures and belief systems perceive health and illnesses, and how they respond to various symptoms, diseases, or treatments. For some cultures, certain disease may not be so significant. For example, hypertension, diabetes, they may not have as much information as they should. So students, you guys in particular, yes, you have to learn to recognize and appropriately address these issues. Mm-hmm. And we have to, of course, highlight that there are major ethical issues that cannot be overlooked. So, for example, the cases of euthanasia, sex and gender issues, because sex, the issue of sex is still a taboo topic in many cultures, and so what often doesn't get talked about leads to a poor understanding of one's own sexual development and those of others. Abortion, these laws vary from country to country, and the views and the decisions of the patients are influenced by their religious beliefs. Blood transfusion is another major issue. There are religious groups such as Jehovah's Witnesses that don't permit blood transfusion. So in that case, there has to be some alternative to that. And there is a difference in racial frequency of certain blood group antigens. For example, in African Americans, in that group. And we also have to mention about a specific population that have specific and even more specialized healthcare needs at this time, and these are the refugees. So refugees, they are different. They're a different definition compared to migrants, as outlined by the UN. So refugees are people who are outside of their country of origin due to a fear of being persecuted while remaining in their own countries, whether that persecution due to violence, war, etc. And as a result, they require international protection. While migrants are people who have a change in their country of usual residence. For example, I live in Saudi Arabia, but I am a temporary migrant here in Poland because of my studies. And so the migrant status may be short or long term. And so refugees, they do require, they have disparities in obtaining access because of the high cost of healthcare, lack of insurance, lack of written status, documented status, I mean, and of course, communication barriers, language issues.
Okay, so one of the questions you submitted was very, very general. How to provide our culturally diverse patients with confidence and make them feel safe with us. And while general, it's an extremely important question, and it emphasizes extremely important concept of patients feeling safe with their doctors. So look, the definition of one of the definitions of professionalism clearly explains that medical professionalism signifies a set of values, behaviors, and relationships that underpin the trust the public has in doctors. And this might be a separate lecture or separate workshop when we could tell you about how much differ the outcomes of therapy in case of patients who trust their doctors and who do not have this trust. So this is not something additional. This is something extremely, extremely important. We were used in medicine to so-called self-regulation, which means that we were doctors were deciding about themselves. And now we know that this is not enough. We need the shared regulations, which means patients also participate in creating regulations regarding healthcare, but also regarding medical education. So look, if we want to focus on so-called patient-centered clinical practice, medical education needs to respond to this. Medical education needs to provide students with the appropriate education for this. And for this, we need not only faculty members to decide about the curriculum, but all patients also. So patients should not be just like exhibits during the studies when you see them as examples of diseases. On the opposite, patients have the right to tell what they really need. And they very rarely say, we would expect medical students to have more biochemistry. No, they say, we want our doctors to be more respectful, we want our doctors to understand us better. So this is a huge paradigmatic change. In this discussion, we need to involve all people. So we need to involve people also from marginalized populations, elderly people, people with mental illnesses, all the issues related to disability. So we need to move from students taught about patients to students taught by patients, because these are the people that really know what are their problems.
So if you look, you can see that there are many categories, right? When we come to talk about diversity, diversity in terms of race, which is of course the most obvious, ethnicity, religion, gender, sexual orientation, and disability. And disability as a category is important to focus on, because it's not as much stressed, it's not as much emphasized on. So we have to focus on providing for disabled people with the correct facilities and ease and help ease their mobility. And so all of these are going to affect your the way that the patient is viewed and the way that the patient is treated. So for example, you're going to see differences in communication styles, diet preferences, values, their habits, and rituals, etc. And we also have a socioeconomic status, which actually covers all of these categories, right? It does not differ based upon these other categories.
And in this moment, I only want to, you could see that
Yes,
towards the period at the bottom, diversity silos. By this, what I mean is that we need to be very open-minded, and we never should focus on our own dimension of diversity, because this is the problem, that people who are focused on one dimension, religion, job, socioeconomic status, sexual orientation, forget about the other dimensions. And the best example is when some time ago, I was preparing another lecture, and I was trying to find a really nice graphics presenting disabled people. And what I have realized was that if you can do this search, if you use Google search and you search for some infographics on disability, then all of the people will be men, or they will be all white. If you search for people of different ethnicities, there will be no people with disability, or there will be no people with diverse sexual orientations. So this is absolutely fundamental, that there is nothing like focusing on one dimension of diversity only.
Mm-hmm. And also, if you reflect on yourself, yes, you might be culturally competent in one category, but be deficient in others. So it's important to keep all these in mind. And when we talk about race versus ethnicity versus culture, I'd like for you guys to take a moment and think about, what do these terms mean to you? Yes, what do these terms mean to you? And do you notice any differences in these definitions, or are they just all the same? It doesn't really matter how we use them. So just take a moment to think. If you want to share what you're thinking about, just type it in the chat, and so we can all read it. So race, ethnicity, and culture, right? Race is a social category that is forged historically through oppression, slavery, and conquest. Most geneticists agree that racial taxonomies at the DNA level are invalid. So race, in simpler terms, would be based on your physical characteristics, right? The appearance of your skin, your eye color, your hair color, etc. And so your geographical ancestry based upon location does not equal to your race. Sometimes cultural practices may be misinterpreted as biological differences, and that's very true, right? We think that a certain aspect of our culture simply because it has been passed down through generations. We continue to do these, but actually, a culture can be changed throughout our lifetime, right? So, for someone who has migrated from one place to another, they can adopt or acculturate themselves into the new culture. And while and ethnicity would be the groups that share a common identity-based ancestry. So that's not based on your physical outward characteristics, but your internal or your felt characteristics. And that's based on religion, beliefs, customs, and yes, the history of migration, colonization.
And we need to especially emphasize the proper understanding of culture. Culture is not only related to religion or ethnic origin. We may talk about culture of students, culture of doctors, culture of health professionals. So you may think, and in fact, this is one of the exercises we do with our students at the very beginning of their medical courses. We ask them to identify what are the cultures they belong to. I can see that we have some this happens quite often when we move between different systems. Sorry for this. Thikiri?
There are, yes, guidelines stated by the EU that they do not process personal data that reveal a person's racial or ethnic origin, political opinions, religious or philosophical beliefs, etc. And that when they do collect such data, you do need a specific protection rights, yes, to protect the rights of such individuals. So we can think again about race as is it a social construct? Is it something that we have given that label, that we have marked, or is it something that has been present since the beginning of time? As far as the EU goes, the EU rejects theories which attempt to determine the existence of separate human races.
And what I want to add is that one of the comments you sent us was that majority of that kind of presentations are prepared from the European point of view. So we are fully aware that this is just our European Union approach, and it differs very much. So our approach is that in our service, for example, in questionnaires, when you admit people to work, when you admit students to the university, we do not ask about race. It is different in different parts of the world, and different parts of the world have different grounding for this. So I'm not trying to say that this is the optimal solution, but this is one of the points of view which is interesting. Just this notion that race was invented by people to make discrimination easier, and this continues till today. And now we have the set of questions asked by you, how you could advocate to include intercultural competence in your university, how to start implementing this, and also the questions about countries with lower income when you believe you may not have resources for this. Thikiri, you wanted to start?
So yes, we try to incorporate your questions as much as possible because you guys really, you wrote down so many varied responses, and we thought, okay, why not just try to, just slip it in there when we get a chance to. And so the first thing would be, how can we advocate, to include this topic into our university? And as I can speak for here, at our university, at the Medical University of Lodz in Poland, we have a very active Center for Medical Education. We have a very devoted team, of course, led by Dr. Dr. Janczukowicz, who strives to better and improve this, delve deeper into this topic. So this topic is actually part of the course on medical professionalism, which is taught to all incoming first years. So we have a course on that, and within that course, it's not just it's not just a lecture, but it is very active. We have workshops, we have activities where students rank their views on what is most important in terms of cultural competence. And so I would suggest to contact, right, if you do have a Center for Medical Education at your medical school, to contact the teachers there and ask for that.
So I will give you some practical advice, because I'm not sure how much you know it. What you see on the left is the first page of the document that regulates medical education in Poland. And most probably for every country, whatever country you are from, you have the national regulations. And I'm just giving you examples, especially not for medicine, but for example, for nursing in Poland. So look, what are the expectations, what government expects the school to teach nurses. look how really important elements of the curriculum are listed here. You can read it for yourself. It goes as far that the recommendations even say that there should be a subject called multicultural nursing. And I could show you the same requirements regarding medical education and pharmaceutical education and so on. So if you identify that it exists in your national curriculum, this is the best way to start advocating, because you are coming to your dean and you are showing we need it. The problem is what happens when you don't have it. Then you may try from suggesting adding this as an extra component, as a student selected component, which may be at first for a small group of students. Later on, if it's working well, you may start developing it. But please remember, whatever you want to add to curriculum, you need to design teaching, learning, but also assessment. Because if you add any element to the curriculum which is learned but not assessed, I can see someone raising hand. If this is, okay, if you want to ask a question, please ask, or just type the question, because I don't see them in the moment. Okay, so let's continue. So remember that we need also diverse learners and teachers. It's not, no one will properly assess intercultural competence if the school has teachers coming only from one culture. The other way how to advocate is to take one of the international documents. And you can see, for example, the document which is called AMEE Guide number 103, which is Teaching Diversity to Medical Undergraduates. This is a guide written by world-known experts in this area. Take it, go to your dean, and discuss how you could implement it for your school. Then there was a really important question: how can research serve in advocacy for intercultural learning? This is absolutely fundamental, because we need research on why we need it. We need research on how to provide students with such training, and we need research on how effective it is. And this is one of the most important issues. We need research that proves that if you provide students with appropriate training in intercultural competence, it changes how doctors work, how they impact the society. This is in fact the subject for a separate webinar. So if you want to separately discuss how to do research in the area of teaching, learning, and assessing intercultural competence, I'll be more than happy to help you with this. This is an example of the online module. Don't worry, what's written in Polish is more or less translated into on the right. So we have not only the modules on intercultural competence at the beginning of the studies, but this is, for example, a Moodle core component, which means that everyone needs to take it, every student, on anti-discrimination, on discrimination and anti-discrimination strategies in medicine. So you can see what are the subjects we are discussing, in this case with four-year medical students. And now I want to address the issue of money, because I know that there may be huge financial problems, but my experience is that if schools have a lot of money, it doesn't necessarily mean these schools go towards cultural competence or communication skills. It may just mean making more posh lecture rooms, or putting more money into simulation centers. And what I want to show you is my friend Dr. Elpida Artemio from St. Kitts. And Elpida, they don't have too much money at their school. Elpida teaches communication, and she wanted to organize OSCE stations, and they definitely had no money for this. One of the problems some kids have are hurricanes. And you know, well, the hurricane, when you have this warning that the hurricane may appear, you try to secure doors and you try to secure windows with wooden panels. So she went to the governor of the island, and she said, if this hurricane is not coming, can I get all the wooden panels? And the governor said, yes. And she used these panels to construct OSCE stations. And she constructed absolutely perfect OSCE exam on communication skills. So this is a really good example that what is much more important is not money, but just the will to act. Again, if you would like to design how to design, implement cultural competence, add it to your curriculum, we may discuss it separately, but this is something very important. Please be very careful if you, with the best intention, create any workshop on this theme. Remember, participant safety is first. And there are many examples of workshops or any other interventions in this area that were hurtful to participants, that resulted in unexpected outcomes. This is not very new, but this is a really interesting publication which evaluates the effectiveness of anti-racist strategies. One general strategy is we need to reduce so-called intergroup bias. So the very basic example, if we have the population of Polish students at our university and international students, never organize a football match between Polish and international students. It's not working. It will increase the competition, involve all the students, that way that they have a joint aim. This reduces that. So this is a very good idea generally how to work to reduce the differences between groups. And remember, no formal teaching will be effective if there is a so-called hidden curriculum. If we teach something different than the school or environment is showing later. This is if we teach students about equality, inclusiveness, and the culture of the school shows something totally different, this teaching is destructive because students see how they teach us this, but it's not related to reality. So I picked up one of the phrases again from your submissions, and it says, I expect learning about the others. I absolutely understand the very good intention of this, but the fact is, it's not about teaching about the others, because if we teach about the others, we increase the feeling of being the other. So it's very important that the school is inclusive. We have very few examples of, for example, talking about disability. We have very few examples of doctors who are disabled, and that makes it very difficult for students with disabilities to feel safe in the new environment. I remember the story from my friend who is a psychotherapist. She has a severe disability of mobility, and when she was admitted to work, this institution was absolutely sure that they have no barriers. The first day she came to work, they realized how many barriers existed in this institution. This is the question which is so complex that we are showing you rather to indicate that we don't want to pass over it, but the reason we'll not focus on this is that it requires a really long session, especially that we need to provide you with safety. So this is the issue of safety in these two problems that are raised here, that is related to the fact that we cannot, we want to discuss it, but we want a lot more time for this. I'm a little bit, sorry, lost in presentation at the moment. So sorry, let me jump back to this. And now, Thikiri, the floor is yours.
Okay, thank you.
Which is this slide. I hope you can see this.
Okay, maybe we can go back to about the LGBT.
Yes, of course. Sure.
Before, just a little bit early, just a little while earlier, someone also mentioned, which countries are actively trying to implement this in the curriculum, and as of now, there is no one uniform curriculum. Yes, for intercultural competence for this course, but there has been studies and there has been a project called the C2ME, the C2ME project that was done as a collaboration between multiple universities in countries across Europe, for example, Finland, UK, and Hungary, and Denmark, of course, Amsterdam, the Netherlands, and so they wanted to come up with a key set of objectives, not just for the students but also for the teachers, because as Dr. Janusz said, it's very important that the teachers who are teaching are diverse and have greater knowledge of different cultures. And as far as when we're talking about this, specific community of the LGBT, of course, their needs, their healthcare needs are going to be different because they are. They are sometimes they're at greater risk for certain diseases, and they may be more likely to seek mental help for mental health issues. So, as Dr. JD said, this is still a very complex issue, and we cannot just start a conversation without anticipating what will be the reaction. And the other question here is how do we deal with patients with traditions or beliefs which are harmful for their health? So, for example, patients who don't really believe in modern medicine, yes, and they prefer traditional medicine like herbal therapy or aromatherapy or other forms of alternative medicine, and in some instances it could be harmful to their health, and they don't know. So we as future physicians, we have to educate them. But first of all, of course, we have to respect their beliefs. We have to tell them, yes, I respect that you have these beliefs, but at the same time, because it is posing a harm to your health, this is what could be more beneficial for you instead. So education, respect first, education. And I also wanted to mention the example of smoking, for example. Yes, this is a behavior, a habit, also an addiction, which is harmful to people, and yet a lot of people are kind of in denial, or they don't want to admit that it's harmful. And so we have, steps. We have the 5 A's, yes, for smoking cessation, and that involves, always following up with the patient and asking them, at each visit, or advising them at each visit, and I think we can do the same for these other patients.
Still, we need to remember that we need to respect people's beliefs and decisions. They have the right to decide. So our role is to educate, but the very good example is this very striking example of Jehovah Witnesses. They have the right to refuse blood transfusion, and we cannot force anyone. We cannot act against their will. Again, this is something we discuss very deep, in great detail with our students, because there are multiple levels of complexity. Perhaps you know them. There may be a conscious patient refusing blood transfusion. There may be an unconscious patient, but having a document called advance directive, and so on and so on. There may be even a child when parents refuse blood transfusion. And for each of those cases, we have certain strategy. So look at this graph, please. When we have minority and non-minority patients, there is usually some difference in treatment. A small part of this difference may be justified. So for example, if the patient refuses certain diet, it doesn't mean discrimination, because you may say, I'm vegan, I will not eat meat. So if you see that this patient doesn't get meat, it's not a discrimination, it's a justified difference. There may be so-called disparity. Disparity means that, let's imagine there is one patient living very close to emergency department, another person living 100 kilometers from emergency department. You may imagine that they will not get the same treatment. It's not discrimination, it's just, unfortunately, the operational sort of injustice. And then finally, we have discrimination. And discrimination is this, it's the reason, the fact that it's only 1/3, it doesn't mean it's only 1/3. Perhaps it's much more, but discrimination is when there is a difference in health service caused by biases and stereotypes. And we will talk about stereotypes in a moment, but now I would like for a moment to refer to your multiple questions regarding COVID and the current situation. And first of all, the second question, what is the best way to approach getting back to normal? Honestly, we don't think we will be getting to normal, because there is nothing like normal. There will be new normal. We believe that there will be huge changes that will remain after what's happening now. And one of the issues I want to emphasize is that currently this pandemic very much increased the pace of movement toward digital health systems. What you can see here is a slide of my lecture that was cancelled because of COVID, because I was to participate in the WHO Europe session on this issue. But what we need to remember, and this both applies to general digitalization of health systems, but also to the current pandemic, is that we cannot forget about this human and cultural dimension. So developing both online teaching and online health services, we cannot lose communication skills, humility, empathy, and we cannot change patients into numbers and data. We still, this is called narrative rationality versus technical rationality. Moving towards digital health systems cannot cause us to forget about the human being behind the screen. So again, we need to involve patients in all of this, diverse patients, families, caregivers, or marginalized populations, because this current shift towards digital health services very significantly affects patients' needs for empathy and compassion. So this looks like it's, there is another trend towards slow medicine, more time for patients, careful evaluation, respect, equity, and we cannot get lost. It cannot be like two separate trends. We need to make it like a joint trend. So for our school, we work with our students also at the Museum of Arts, and this is one of the trends in medical education, which is using humanities, and it's not to discuss paintings. It's to discuss issues of culture, issues of war, issues of injustice. You can see, of course, with their permission, published pictures of our students. Our students make drawings which not only present tensions between their academic development and future practice, but also show the stress. And we are very focused on patients, students, and teachers' mental health needs, well-being, resilience, strongly remember about all the problems related to cultures. And currently we have the social isolation, we have the threat of the disease, we have this shift in teaching, learning, uncertainty regarding promotion and graduation, but also impaired access to healthcare. But we have also multiple psychological advantages, unexpected psychological advantages of this situation. I will refer to it later, but we need to remember that We have also maybe shift, but first of all, problems with reaching both students and teachers and patients with psychological support. This is one of our recent projects who asked our students and young doctors, young residents, to submit pictures that represent their feelings towards during the current COVID crisis. We wanted to increase the creativity of students, but also we wanted to understand their needs to adjust our support for them. What we could see was that initially, these are words of participants of this project. You can see many negative emotions, but what was rising a little bit later was just waiting for what will happen and finally waiting for new directions and just hope that we will change into better. So we feel that during this crisis, we started being a more coherent group of students and teachers. And this is very important because we sort of have a common enemy, which is the pandemic. So we know that there is nothing like two tribes of students and teachers. We are together doing what we can to solve all the current problems. So for you, for the students, I strongly believe that students are perfect leaders in change. So I really like this E4 strategy from Professor Stephanie Marshall, who says that if you want to be a leader, you need to be engaging, energized, empowering, and you need to be constantly engaged. And this is what you need to do to promote cultural diversity. The problem is how current situation affects empathy of future doctors. And empathy is necessary for understanding the complexities of cultural diversity. And another problem raised, a very important problem raised by one of you, that there are also those tiny differences, not only the huge differences between different ethnicities and cultures. And for this, we want to introduce to you the term intersectionality, which means there is nothing like universal Muslim, universal Black person. No, because each of us has gender, culture, ethnicity, religion, and each of us should be treated individually instead of being treated as a group of people. So please remember that when you move to another work, you need to deal, we are usually very well prepared in very basic things like how to treat diabetes. I mean, what's the dose of the drug, but how to communicate with patient and how to convince, how to make this patient understand how important is the therapy and that they need to follow your therapy. This is something that will differ between countries, regions, and this is something we really need to learn to be effective doctors in the future. A very good question, how to avoid disrespectful comments regarding different cultures, how to be sensitive. And let me give an example. When my friend who is the professor of Islamic law, and she's a very religious Muslim woman, was working with us, and we went just for dinner, and there was another professor from another country with us. And he's a really nice person. And during this meeting, he was constantly telling jokes, and every time he was telling a joke, he was just clapping her shoulder. And every time he was doing this, I could clearly see, everyone could clearly see that she was unhappy with this. She's a very open-minded and very cultural, very contemporary person, so she didn't tell anything. But every time he was doing this, she was not smiling. And it was so easy to see, if you do this once, someone is not reciprocating this and doing the same to you, just stop doing this. And we had a nice conversation later on. So it's how to avoid disrespectful comments. Just observe people, observe how they react. Remember that empathy is a very well described process. It's a very well described physiological process we can develop it. We have this developed, each of us has empathy developed at different levels, but we may aim to develop it. And recently in Poland, we have many marches in support of people in the USA, and this is a very famous picture from this one of Polish marches. What you can see here, "Stop calling me Murzyn," is a Polish word which many people of Polish ethnic background perceive as neutral, but people of African origin, they perceive it as negative. It's very easy. If someone perceives it as hurting or negative, just don't use it. Don't try to convince them that this is okay to use it. Just don't do anything that is hurtful for the other people. You may think why you can see on the right this deaf culture, because it's an example when you need to, how much you need to know culture. Sometimes we are afraid to use certain words, being afraid that maybe we should say a non-hearing person, while on the opposite, people who are deaf, they form a culture, they are proud of this culture, and they want us to use the term deaf culture using the capital D, because they use their language, they have their values, their beliefs. So again, it requires knowledge to know how to address people. The same applies to disability and disabled. And you can see a really interesting slide showing which terms should be used and which terms shouldn't be used. And you may be surprised because this slide says, don't use term people with disabilities. Some people believe it's good to put a person first, to say it's not a disabled person, it's a person that has disability. The truth is the person doesn't have disability. The person has some impairment and the society makes this person disabled. So the proper term is disabled person, because this person is disabled by the society that creates barriers to certain impairment of this person. It's really, you may find this easily online, and it's really interesting to understand those do's and don'ts. So look, these are just really nice suggestions what to say instead of statement that put people into categories or exclude some people. If you have some people have problems with addressing genders, it's really good to use plural in English, and instead saying she or he, first of all, because it's not inclusive, but also because it's just unnecessarily complex. Just use term instead of he or she can, you may say they can. And remember that the best term to use, because some people don't understand all the complexities of terms, transgender, transsexual, gender neutral, agender. Remember that the term trans, especially used with this asterisk, is a very good universal term to address in a proper way all diversity of genders. And now we are coming into, in a moment, Thikiri will speak, because we are coming into this very complex category of what happens if we don't have proper skills in intercultural competence. You may see this slide, Thikiri.
So this brings us to the topic about cognitive biases and the stereotypes that ensue. So I think we can all agree, yes, that each of us have our own set of prejudices and biases, and they accumulate over time, right? As we grow up, and as we're exposed to different people, different environments, different things, experiences, and we develop such biases. And so there are over 20, maybe up to 50 types of biases that impact and influence our day-to-day judgment and decisions. And so while these biases, and you can see the picture here, it just shows you some of them. So for example, information bias, overconfidence, placebo effect, of course that applies to patients, right? And stereotyping. So while these biases are not possible to be fully eradicated, we can make conscious efforts to adjust our attitudes into actions that serve in the best interest of the patient. So coming to stereotypes themselves, so in many cases, they are manifested at a subconscious level. So we don't really, think about that. We come across a situation, we come across a person, and we just, it automatically forms in our mind. And then afterwards, they are reinforced and they're spread in different settings, for example, in entertainment settings, right? What we see on TV, through social media, in stand-up comedies, right? These stereotypes, they often become the punchline of jokes, or they're needed for you to get the joke. So they're viewed by the public as generally harmless, and that's why they become accepted, and nobody really kind of points that out. So, but in the context of healthcare settings, or in any setting, in fact, we should not reinforce them. And maybe you guys have heard that, we can divide stereotypes into negatives and positives, right? But the thing is that there is no such thing as positive stereotypes. And why is that? Because positive stereotypes, they can actually inhibit, they can hinder one's ability to perform. And they can also cause depression and alienation from the particular group if that person doesn't possess the expected feature. So when we ask, okay, are they even worse than negative stereotypes? We'll see. So back to that sentence about, minorities, for example, African Americans, yes, or Asian Americans, for instance, tend to be less likely to adhere to prescribed treatment plans. And how can we explain that, right? How can we explain their low compliance? It could be due to stereotype threat, that there's the unpleasant psychological experience of confronting negative stereotypes about race, ethnicity, gender, sexual orientation, or social status. And so the experience of stereotype threat can impair intellectual function and interfere with performance. So when there were performance tests that were conducted on students, for example, yes, from these minority groups, they actually performed poorer than what was expected. And if we look at this set a series of boxes, we can see that these stereotypes, they actually are harmful. Yes, they actually are harmful, and they lead to poorer adherence and sometimes even avoidance of the situation altogether.
Okay, so now there is another problem. There is a very famous paper, which is now quite old, and we have many consecutive papers, researches, which were investigating this very scary finding, that African Americans that had exactly the same degree of development of cardiac problems were receiving worse treatment than white Americans. And interesting, what was revealed, they had exactly the same insurance. And doctors who were choosing the therapy they were surprised with this finding because they were saying, I don't have any prejudice against cultures, religions, and minorities. So clearly they had this prejudice. So this is something we cannot exclude. Each of us has prejudice. Instead of saying, I have no prejudice, we need to self-reflect and we need to try to identify our own so-called implicit stereotype. What is my unconscious attribution of particular stereotypes applying to center groups? And there is a very, very famous internet site. You can see the address here, Implicit Harvard Education. And if you want, please check it. And then you can perform the test that will allow you to evaluate your own stereotypes, your own biases against gender, age, religion. This is really interesting, and this is really a really good activity. Some schools make it a required component of teaching in that way that students need to take this test and it is evaluated by teachers. For our school, we believe it should not be done like this. We encourage our students to take it, and then if they want to talk to us, they may meet us and discuss the problems that arose from this. So look, this slide sort of summarizes the changes. We started in the past from teaching so-called cultural competence, which is teaching that Christians are like this, Muslims are like this. Later on, we have realized, no, it's not the truth, because there is nothing like what we said before, one universal Christian, Muslim, African American, European American, and so on. So we moved towards teaching intercultural competence, how to communicate with different cultures. And finally, now we are moving towards teaching cultural humility, how to respect every person. And this needs to be based on our own self-reflection and our empathy.
I think it's very important for each of us to identify and like Dr. Janusz said, to reflect on our own prejudices, our own biases, because whether we admit it or not, they are there, and they creep up on you in unlikely situations, right? So but the good thing is that. If you are someone, yes, if you are a person who identifies with more than one culture, yes, and you've had that opportunity to come across people, to meet people, to talk to people, or talk to patients who are different than you, then you are better equipped and you're better able to adapt to these situations. Yes, so there is a good side to that. So implicit.harvard.edu, if you get a chance, go there and try to take the test, and just as a way to learn more about yourself. And so what is the approach to becoming culturally competent, right? So when you meet the patient for the first time, you want to begin with the right mindset. So even before any words are exchanged, right? And you're seeing each other for the first time. And that creates that initial first impression. And so first impressions, they actually reflect more about ourselves than others. And also remember that first impressions can change, right? So have that right mindset that you're going in there, you don't know the person, but you want to know more about this person, where they're from and who they are, etc. Then of course you want to acknowledge the patient, the person in front of you, and that involves humility, openness, and altruism, right? That sense of, okay, I'm here to take care of you, and here to focus on your needs as opposed to myself. And so, for example, yes, when someone says that I am someone who doesn't see color, then that would be contradictory, because you're not acknowledging the fact that that there is, you know, that we are all of different colors and different, you know, complexions and things. So that would be contradictory. Then once there's acknowledgement, there's the process. So the process of understanding through polite questioning. So, for example, if you find out that this patient, yes, of a particular status is uninsured, then of course you want to find alternate solutions, right? How can they get the care that they need despite being uninsured? And then once you accept, yes, once you accept this. Once you accept and you have more information, then there's a joint decision making, right? Because the doctor and the patient, this is a partnership. And so even if the patient has trouble understanding what it is that they're expected to do, it's still very important that they agree with you know, the prescribed treatment plan. For example, again, when we're talking about the same uninsured patient, you as a physician, right, you might recommend, okay, let's switch to medications that are more affordable for the patient. And if the patient accepts that, then that would be a progress. And then last thing, after your encounter with the patient, and then for future encounters, you have to adapt, right? So because not every patient is going to follow the same values or beliefs, even if they're from the same culture. Okay.
So I want to add a comment that, again, every bullet point from this list, in fact, requires a long discussion. So, for example, this using medications more affordable for the patients, you need to be aware that one of the major factors behind patients not following our advice, not following the treatment plans, is the financial problem. And people are not very willing to admit it because they are ashamed very often that they have no money. So even the way you communicate with them, if you tell them, can you afford this medicine? Very often they will tell you, yes, I can. Instead of this, you may say, so there are two options. This medicine costs that much. This medicine is much cheaper. Which one do you think I should? It would be better if I prescribe to you. Then they will probably choose the cheaper one. So there are a lot of strategies, very, very delicate strategies that you need to use to communicate properly and to make people feel safe with us. Before we switch to now your current questions, I want to show you, to encourage you to read more and to maybe do a small homework based on works of Peggy McIntosh, which are called generally Power and Discrimination. So we talk a lot about how people are disadvantaged, but very rarely we think how privileged we are. And this is really important to understand it, how many privileges we have and we don't realize it. And very often it's very complex. So someone may be disadvantaged because of ethnicity, privileged because of financial status, disadvantaged because of gender, and so on and so on. But look at these questions and look that for you, it may be not a problem at all, while for the other people, it may be a really huge problem. Look at this statement: I can travel by air without having to worry that I will be picked out of the line and have to answer questions only because I have a hijab or I have a certain kind of clothes. The last statement, which here is presented at this very mild form, where some people are constantly asked, where are you from? They say, from UK. No, but where are you really from? Like, no, I'm really from UK. But there is a much more cruel version of this, which we can unfortunately see in real life, on TV, on news recently, when people tell people to other ethnicities, if you don't like it, go home. But this is my home. I'm not from another country just because my skin has different color. So please reflect after this meeting on all the privileges that you have and you are not, that we have and we are not aware. And in fact, this may open a discussion if you still have the time for some additional questions. So I think I will stop sharing the screen. And now I think we need some help from our colleague panelists. If you could help us with some questions that you might identify during the meeting. Chaitra maybe, or if you want to chat, now I will switch to chat. Guys, if you have any more questions.
I don't see any open questions. There is a separate window for Q&A, and there's the general chat.
The last slide that you could see, maybe I will still, before you ask more questions, the last slide you could see, again, may be used for just for your own, wait a moment, maybe used for your own reflection, because it's really good to reflect on your own experience as a patient. If you have ever been a patient, if you have ever been a patient in the other country, what was your experience? How did it differ from your expectations? Thikiri recently was dealing with a similar situation, yes, with your colleague.
Well, yes, I wanted to bring up this issue, you know, and to tell you to consider yourself as a patient, yeah, because it always gives a more balanced view when you can see things from two perspectives as opposed to just one. So right now, you know, we spend all these years learning about how to be the best physician that we can be, but you know, not considering how the other side is. So if you know, maybe you just had a simple flu, right, or a simple cold, not COVID related, of course, and you had to go to see the doctor, you know, as an emergency situation, or you had stomach pain. And so personally, I've been fortunate that you know, I didn't require medical attention, but my friend had to be hospitalized a couple weeks ago during this time of COVID, and her experience was it was very short. You know, she stayed overnight at the hospital. She had stomach pain, and she was discharged just a few hours later the next morning on and given, you know, a prescribed a drug, yes, a PPI. So, but the issue was with the payment, right? Because at the hospital, she wasn't told anything about, you know, how much it would cost, and you know, how would be the payment, all of that, and then just maybe 2 weeks later, she got the notice about this fee that is due. So I think there may have been a barrier in understanding, definitely a language barrier, or maybe, you know, or maybe it's just something that is not told to the patients, right? That, okay, we will bill you once you are discharged and not while you're at the hospital. And as Dr. JJ told me, this varies across countries. So you have to know your country's, of course, the medical system, the healthcare system. Okay, there's one you.
Again, guys, if you want to speak, if you want to type, please do this. I think, again, I will share for a moment the screen. So look, this is a very old model, and there is a lot of there are many following publications which are quite critical, but generally it becomes valid that there is this range of cultural competence, from cultural destructiveness and racism. And we will never achieve the cultural proficiency, but this is our aim, to move towards the cultural proficiency. So, Thikiri?
Yes, we actually have 2 new questions. So would you should we answer those and then I'll do the
Excellent. For me, it's difficult to switch. Now.
Okay, do you see the chat window?
Yes, now I can see this.
Okay, so Carolina asked,
how to act when a patient doesn't want to be treated by you because you are for, well, it's okay, it's a very good question. And this is even something we have a case, as a case study for our students, because you may expect patients refusing you to be treated because of your gender, because of your ethnicity, because of your religion. And this is something our international students, I think they may face during the, we can give you an example. Poland is generally a very monocultural country, which we may find as something we are missing, because it would be wonderful to have more cultures, but it has a deeper background that makes you reflect that it's more complex because we are monocultural, because we had no colonies in the past. And I think we should be more than happy not to participate in incredible discrimination and injustice inflicted on people. But as a result, apart from big cities, we are quite monocultural. So people in some regions of the country don't see often people of different ethnicities, different religions. I would still say that at this moment, we need to be patient-centered. So while you may not feel okay when patient tells you, I prefer a male doctor, I prefer a female doctor, but the patient is the most important person. And you may expect, for example, being a woman, that you have the right to choose your gynecologist of obstetrician that you feel comfortable with. So if this is possible, I would say we need to provide this to the patient. But at the same time, we need to educate, and this differs between countries, because we know that in different countries, for example, using the same example, women, in some countries they prefer male gynecologists, in the other countries they prefer female gynecologists. But I would say always the patient is in the center, and sometimes it's not the time to educate the patient. We need to help the patient to feel safe. And of course, at the second level, we need to educate the patient that we are really good doctors despite our external characteristics. Thikiri, do you want to add to this?
No, no, I think we can move on to the next question by Hannah.
I would say that it's not saying that it cannot affect. I think it's about admitting that it affects, reflecting how it affects, which are the areas that are acceptable, and which are the areas when you need to clearly identify that there is a conflict between your beliefs and patient needs. And again, it's always the patient that is in the center. But definitely it's not, all we were saying was not saying your own beliefs should not affect it. It's about self-reflection, how it affects it, and what can I do within this area to provide patients with the best care.
Marcel had a question in the Q&A box. What advice would you give when going to a medical system in a country in which you're having an exchange? For example, Erasmus, I presume. What should be asked in order to not get surprised during the program? Do you mean while you're at the hospital?
Well, first of all, it's really good to know where you are going to go. Yes. And it's really good to read about culture. It's really good to read about local beliefs and traditions. And it's your free decision to go there. So remember, if you go to the country, respect the country's tradition and respect the country's regulation. We have so many cases of tourists who are surprised because of the fact they were arrested because of their behaviors in certain countries which are accepted in their own countries. But if you go somewhere, respect the people that are there. So it's a really good idea. If you are into very much, just let's be honest, if you are very much into partying, it may be not the right choice of the country, which does not alcohol, which does not many activities which are absolutely accepted for your country. So it's not about asking particular questions. It's about, I think it's always a great experience to go to the country that's very different, because then you'll learn to appreciate different culture and to respect it. But of course you need to get prepared, and you may find people online, you may find people, it's so easy, I don't need to teach you how to find new friends from the country you are going to visit, and to learn how to be respectful where you go there. Thikiri, somehow you see more questions than I see. If there are any more?
No, they're just going back between the Q&A and the chat box. There's another question from Augusto. How can I resolve the conflicts that begin between other person with a specific culture and I about health topics during a research, during that exchange, in an exchange?
Okay, just let me read it and think if I...
Mm-hmm.
Augusto, I'm afraid I don't understand totally your question. If you want to explain it in greater detail, you may email me later. I will show you we'll show you our email addresses. I understand that you do the research, any research in an exchange, you should have the bioethical committee permission. This is what we teach our students when we teach research. When you plan the research, you need to design a research proposal. You need to send this research proposal to the bioethical committee. Your research proposal should include very strong elements. How will you provide patients with safety? Safety includes, let's say, cultural safety, emotional safety of the patients. So I think there should be, in fact, there should be no conflicts between the person and you on this, because it all should be well designed, well planned, and very carefully evaluated regarding the patient's safety and well-being. But if I'm not answering your question, just again, you can email me and we can continue this. Okay, so shall I be back to the slide, the final slide from Thikiri? Is there just only the summary?
Okay, so just as a final summary, I think we're coming to the end. But yeah, takeaway messages out of this webinar. Again, approach with the right mindset. The first impressions are made even before you exchange words, right? So based upon appearances, and so the right mindset would be, okay, I do not know this person, but I need to know this person to help them in the correct manner. Do not be afraid to ask. Asking questions is the best way to learn about others. Miscommunication is not exclusive only to people who speak different languages, right? We can have miscommunication even among different dialects. So do not be afraid to ask, politely question, right? And do not assume the answer. The answer is going to be the same as what you're thinking. So use what you already know, the knowledge you have beforehand, to ask further questions. clarify when in doubt, to increase understanding and fill in those knowledge gaps, and get help when necessary. So if there's a family member with the patient, or a translator who can act as a liaison. Remember that every patient is different, and so one patient's beliefs may not apply fully to another patient, even though they're from the same culture.
Okay, so guys, if you expected the session when we'll give you just tips and tricks, if this is a Muslim person, don't give this person gelatin capsule or don't give alcohol. This was not our purpose, and this is not what you could hear here. And again, you may have this feeling that we opened hundreds of boxes on every slide, but this is only to indicate you how complex it is, and you can both investigate it further on your own, but we're also very happy to help you with this during possibly further sessions or meetings.
Mm-hmm. About that, one of the questions that Hannah asked about, having that strong religious belief and not letting that affect the way I treat my patients. I think personally, I would not broach the subject. I would not approach a subject unless the patient starts first. So if the patient is open to knowing more about my religious beliefs, then I would feel it appropriate to share. Otherwise, I would focus on the patient's own religious beliefs.
I think Chacha is trying just to say something. So
we just have one more question from Liliana. Just thought if you could answer before we end.
Okay, so we can see the question. You're attending an internship in a hospital. How can your superior make a racist, sexist remark towards a patient or acts in a non-professional way? How you can approach the topic in an escalating way? This is a really good question and very difficult. And sadly, medical students don't get as good training in this as, for example, nurses get. Nurses are being taught very specific strategies, how you should behave in moments similar to this. And this is very related also to situations when you believe that your superior is close to or is committing a medical error. So there are very detailed strategies. And again, if you email us, I will send you the strategies which tell you how to behave. First of all, to provide the patient safety, but let's be honest, also to provide your safety, because of course you may be afraid of the superior. So please contact me and contact us and we'll send you some strategies.
Brilliant. Thank you both to Dr. Janusz and to Thikiri as well. We didn't have any other questions on the Facebook Live either, so I think all the questions they wanted to ask has been asked. Thank you all very much for that wonderful presentation and explaining everything in such great detail.
So thank you so much. And we'll just show you, in case you want to contact us. So there is a slide with, okay, so you can see that if you want to email me, you may use our departmental email address, which is on the left, Medical Education. And if you want, this is sort of sad because Thikiri is showing her Gmail address because very soon she will not be using our university students' email address because she will not be our student anymore. She will be a young doctor. So again, thank you so much. If you want any closing comments, please tell, or any feedback.
Once again, thank you for the lovely presentation. For those who've attended the webinar, if you can fill out the post-evaluation form, that would be really useful for our panelists and for future webinars from the Scopie and Advocacy side. I've just put the link in the chat box once again. This webinar will be available on YouTube, I believe, for anyone who wants to see wants to see it again, and because there was a lot of boxes opened, and it would be very interesting to read up on all of those aspects.
Okay, so again, thank you very much, and I think this is helpful today. So have a great evening or afternoon or whatever is time at your time zone. So thank you very much, and
Thank
bye-bye.
you very much for everyone that attended. Thank you, Dr. Janusz, Thikiri. Thank you so much for making this amazing presentation. I already saw many comments from my friends. I received a lot of messages already on my WhatsApp, good comments. So I'm very, very happy that you covered amazing areas, things that we never expected that you would like go like that deep. And I'm very, very happy that you would make like such amazing comments. So thank you very much. And for you guys that are here, I would like you to not forget to check IFMSA Instagram, IFMSA, and it's Global Health Weekend Day 3, and to just go and answer. I don't know if you can see. Oh, damn, it's bad. So just do not forget to answer the questions. Question 1, what can we do to improve access to healthcare? And question 2, how can intercultural competence provide patients with the best possible access to healthcare? Share your thoughts and enjoy, and do not forget to answer our evaluation as well.
One final thing, because we were discussing very sensitive and difficult issues. Sometimes with the best will and the best knowledge and skills, we may say something that is not correctly understood, or still may be somehow hurtful. So in case you disagree with something we said, or in case you think that it should be said in another way, please let us know, and we'll be very happy to reflect on this, because we learn all the time. So this is really important for us to know that there are some issues that should be maybe covered by in another way, or are even more complex than we believe that they are. Okay, so again, thank you very much.
Thank you. Thank you all.
Thank you, bye.